Welcome to the
There we go.
December 2023 Diner on Atypical Parkinson's. Thank you, Dr. Amber Van Laar and Dr. Victor Van Laar, for making time for a diner. Once again, we appreciate both of you. And take it away.
Yeah, no, I appreciate being here as always, and there's always great questions from this group. And this is a kind of off-topic in a way. So, there has been some requests about having a bit better understanding for the atypical Parkinsonisms. This is really a kind of big bucket in some ways, and I think the other thing that I've noticed in this group, but in other Parkinson's groups, that sometimes there are the atypicals that have nowhere else to go, and so they have sometimes found a home inside the Parkinson's community, just because some of these diseases are actually quite rare, and so this is why I think it's worth spending some time talking about these today. Now, I am a little bit cautious here because this is kind of like a mini residency. This is definitely going to be, a lot of information that most people have never heard of some of these diseases, but there are some kind of cool features. And so I wanted to kind of go through, if it's not Parkinson's disease, but it sure looks like it, what else could it be? So please stop and ask questions, and hope you enjoy going back to school here a little bit with this. So when we say atypical Parkinsonisms, we're talking about mimickers of Parkinson's disease. So these are conditions that look to most people like that this is Parkinson's disease, when in fact it actually isn't. And we can sometimes only really feel confident that it's not Parkinson's disease over a little bit of time, and seeing patients over multiple months to be able to say, well, gee, this is not kind of hitting some of these key criteria to say Parkinson's, or it's just not progressing in the way that we would expect to see in someone who has Parkinson's disease versus something atypical. So there are a few red flags that we look for when we're thinking about an atypical. So if someone is coming into the office, it's maybe your first or even second time meeting them, and they're already complaining about a lot of falls, a lot of problems walking, or memory is already a big issue. Like there's maybe already concerns for like straight up dementia, or this what we call dysautonomias. This is where the autonomic nervous system isn't working well. So that's like you're not automatically controlling blood pressure or sweating, things like this. If those are the things that are first coming into the office and that are being complained about, that is not typical for kind of run-of-the-mill Parkinson's disease. Another great way to kind of alert us that there's a problem is, we have things like levodopa, other medications that we use. And for some of these patients, if they aren't responding well to these medications, or at least in a way that we would expect, based on experience with other Parkinson's patients, this is another kind of clue that like something's different here. Most of these conditions don't come with tremor, not the very particular kind of tremor we see in Parkinson's, which mostly happens when you're sitting down, not thinking about it, and that's when the tremor, you're just relaxing at rest. This is when the Parkinson's classic tremor really comes up. And so sometimes if there's no tremor, or it's affecting different sides of the body in different ways, these are again clues to help us say that this is maybe not Parkinson's disease. And typically, one of the other kind of hallmark features that you'll see throughout all these discussions, one of the things that's pretty common amongst all of these is that the progression is actually a lot faster for a lot of these conditions. And that's again where seeing people over multiple time points really helps us kind of say, this is something different. So kind of keep these ideas in mind, and as we kind of step through some of these other atypical Parkinsonisms. The first one I'm going to discuss today is called progressive supranuclear palsy. Very big name for a fairly rare condition. The picture you're seeing here is actually someone who has problems seeing. Specifically, the eyes don't move very well. And this is what they're trying to show you in a static picture, is that someone's being asked to look down. And so voluntary eye movements down are a real problem for patients with PSP. And so this is actually one of the great tools that we can use in the clinic to try to understand what's if this is PSP, for example. So, similar to Parkinson's disease, the onset here is around, let's say, like early to mid 60s. But the big difference is the rate of progression. I mean, this is, Parkinson's can go over decades, not for not everybody, but compared to, less than a decade for someone with PSP. So again, what the things that we can see on exam, and this is, I think, some of what the questions I had heard previously is like, well, how do you know? And a lot of this is really based off of just experience, knowing what Parkinson's looks like in all its variety, right? And what doesn't look like Parkinson's. And these are some of the things we can see on exam that say, that's probably something else. So again, PSP is this really strange, because of where the lesions are happening, and mostly in the brainstem. Patients can't push their eyes down. So there's really a lot of restriction in how to move the eyes. And this is a great quick assessment we can do right at the bedside to say that there are problems moving the eyes around. And then this is also a group of patients where balance and falls become a big problem. Like, again, first visit, we're usually hearing that falls and balance issues are a key problem, like in the very, very beginning. And one of the other kind of sort of stereotypical features with patients with PSP and their falls is that they tend to go backwards. And in fact, their posture is almost kind of backwards as well. And it has a lot to do with just where in the brain there are problems and where the degeneration is happening. Just a few other things that we can see on exam or just from history. So unlike Parkinson's, which tends to affect one side of the body more than another. So both sides get affected, but usually there's one that's the worst side, right? PSP tends to be very symmetric, like both sides tend to be affected kind of at the same time in the same way, very, very equally. That is not typical for Parkinson's. But just like the reason why it can get mistaken as Parkinson's is because people are slow, they're stiff, they have a lot of rigidity. But unlike Parkinson's disease, where the rigidity is really arms and legs, theirs is really, neck, back. It's all kind of the spinal column where they're just really stiff. And they, again, their posture is kind of held back. And these are, again, quick glimpses of things where, even walking in from the waiting room, you can sometimes start to pick up on these things. Also in PSP, and again, this is something you can see in Parkinson's, the problems swallowing, the problems talking. It's different in PSP, and again, it happens a lot earlier in the disease course. And again, I mentioned this in the first slide, but patients with PSP tend not to respond to levodopa or the typical Parkinson's medications. And it's because it's not Parkinson's disease. And so the dopamine cells themselves are not the main problem here. And then there's a funny little clinical sign that we call the Proceres sign. So we like to have little, clues that we can see. And so this is what the Proceres sign is. It's sort of like a frowny kind of look, like someone's upset or surprised almost, or the muscles here are just tight, and it makes people look like they're frowning all the time. So if you see kind of this look in someone who's kind of, sitting back like this, the posture is just kind of tilted back. I see that coming, from the waiting room, and I'm like, this PSP is like on the top of my list, even just walking into the room for the first time. There's also something called the hummingbird sign. So we love our MRIs, and this is one of the things that helps us say, okay, this kind of is consistent. It, looks like a duck, quacks like a duck, it might be a duck kind of situation. And so what they're trying to say here is, I don't know if you can see the picture of a hummingbird here, but there's a lot of, this is where a lot of the problems happen in PSP. This is where a lot of the degeneration happens. So this is the midbrain. This happens to be where the substantia nigra and all those dopamine cells live, is in that same areas, which is why they look Parkinsonian. But we see this very, very specific loss here in this look, and it's like, okay, this is probably consistent with something like PSP. But again, for a lot of people, especially if you are not trained in picking up some of these little clues, a lot of patients with PSP are often misdiagnosed as having Parkinson's disease. So if you recall from a lot of prior conversations that we've had, Parkinson's is the protein that gets accumulated or built up in Parkinson's is primarily alpha-synuclein. It's a little bit different in PSP. So we have a protein called tau that builds up inside the brain. This is actually kind of a newer technology that's come up recently where we can actually image tau inside the brain. And this is, I think, is going to be a huge leap in helping to understand PSP a bit better and maybe even come up with better treatments, because there's a way to look at this now. But I think you can see, like, here's someone with Parkinson's, and tau just isn't a big problem. It's not like the thing that happens in Parkinson's disease. As you can see, sure enough, there really just isn't a lot of tau buildup. Whereas in early PSP, these bright red areas, this is to suggest that this is where tau is building up in the brain. And this is exactly where I just showed you the hummingbird sign. And this is where you can start to see a lot of damage occurring. And this is also happens to be where tau is building up as well in the brain. And so we know tau is involved somehow. I think that we still don't really know for all these diseases. We don't really know like the cause, because it probably isn't like one cause. But we, for sure, just like with a lot of what I'm about to talk about, age and the environment, are definitely playing a role as well. And for some of these conditions, I think the jury may still be out whether or not genetics are involved on top of that. But knowing tau is a problem kind of hints that maybe there's something there. But again, it's a rare disease. It's hard to study. It's hard to recruit for it because there's not many people with it. But I can see a lot of promise, a lot of hope. And I think doing some of this imaging is going to be a big help in pushing this disease forward. Are there any questions about PSP before I move on?
Donna was asking what the technology is that's being used to show these tau proteins.
Yeah, so I'm trying to think of a imaging study you might be familiar with, but there are ways of putting a little signal on top of the tau proteins inside the brain, and that signal then glows, in the these different types of imaging. So I don't know if this one's SPECT or PET, but there are ways of doing imaging that say that they label the tau, and that allows us to see it in the imaging machine to then say, okay, no, it's there. So you have to have enough of a tau buildup to be able to see it. But this has been a big leap because tau was a problem in something like Alzheimer's disease as well. So the pattern in Alzheimer's looks very different than what you see here. Again, will help a lot of the tau related diseases. Are there any more questions? Okay. Then I'm going to move on to the next tauopathy. This is called corticobasal degeneration. So this is a rare one. This is rarely comes through the office, but it's there, and I think it's important to know what it looks like. But I use this picture because I think what's interesting is this is a really interesting disorder to a neurologist, but what you're seeing here is alien limb. So this lady's trying to show you she doesn't understand whose hand this is. So just like this picture here. So I think you can appreciate this is a bit younger of an onset. So the age of when someone comes in, that's like one of the first things you need to kind of pick up on, because that helps to decide, who fits into what sort of category. As I mentioned before, this is a faster progression too, maybe not as quick as PSP, but definitely more aggressive than Parkinson's. And it's a Parkinsonism, so people move slowly. They have a lot of rigidity. They have dystonia. All the things that we can see in Parkinson's. But what's really unusual about CBD is that it tends to affect just one side, and it's like just locked on one side. So you can have very severe rigidity. Like I remember just trying once this one night to just move the arm a little bit, and it was so rigid. And again, for someone who had just had symptoms for like a year or two, so that was very unusual for Parkinson's disease. So this, like, I mean, it's dramatic asymmetry where you could be almost completely normal on one side and have severe Parkinsonism on the other side. And again, that's very unusual for something like Parkinson's disease. But then you add on top of that, on the side that's affected, there are some unusual things that we can see on exam, but that are great when you're trying to teach someone, but are a problem, big problem for patients that live with this. So there's something called graphesthesia. So I'm sure many people have done this with their friends or when they were kids, but you write like a number on someone's back and you have to guess what number you just wrote. This is a skill that they would not be able to do on their affected limb. So we'll write numbers on the palm or a letter, and we have to ask them to guess, and they will get this wrong a lot because it's that ability to take that sensory information, incorporate it, and then get the right answer spit back out. They cannot do that. The stereognosis, so this is the ability to kind of know where things are oriented in space. It's a sensory issue as well, and that's a big problem for them. There are some fun things called like apraxia, and I have a slide on this in a minute. Aphasia, meaning that there's problems with their speaking, so it's actually getting words out. And then a fun one called alien limb. There's some interesting videos that go through this that you can take a look at if you're interested. And this is actually kind of a cartoon version of what this looks like. So for reasons that I think we don't understand very well, again, on the affected side, this is, again, tends to be locked on just one side of the body. that limb, that hand, usually, it does things that you don't want it to do. And the person is not in control of their own arm, for example. And so what you're seeing here is a picture of someone who's trying to just pour a cup of coffee, and all of a sudden the hand just dumps out the cup of coffee. And so this is embarrassing. It's frustrating. Like, you can't predict it. There's no good treatments for this. And it's just I can't imagine living with a part of your body that you cannot control. And this is what these patients experience on a daily basis. It's very frustrating. And for crazy reasons, it's usually really complex behavior, like dumping this cup of coffee. I had someone who threw a glass of beer. So, I mean, there's a lot of very, very strange things, and it just shows you how amazingly complicated the brain can be. I show this because I was just stunned when I saw some of these pictures, pulling this together. So this is looking at someone's brain that had CBD, and then they passed away. And then this is how we diagnose for sure this was CBD. And what you see is, these look like two different brains, but I assure you, this is the same brain from one person. And you hopefully can see the big differences between the two sides of the brain. So this side is what we call atrophied. So it's very shrunken, and it's a lot smaller than this side. And this is because this was the side of the brain that was really affected. And even looking on the outside, you can see how much smaller it is than this side. When you take an image of that same sort of brain, this is what it can look like, where you see all this black here, that it's a hole. I mean, there's no brain tissue here, because it's been atrophied, it's been really shrunken. Whereas the exact other side, it looks pretty good. And these are real hallmark features of CBD, this cortical basal degeneration. Again, it's so odd to me that you would have, one brain that looks so different on the two sides. It's just one of the mysteries of this particular disease. But it's because of this asymmetry in the degeneration, that one side is just really, really bad. The other side's pretty good. And that then this is what causes a lot of the other problems. So I mentioned apraxia. So the type of apraxia that affects these patients is it's the inability to perform these motor tasks. So the picture here, I'm not sure if you can appreciate it, but the cone is upside down, so it's not working. And so it's close, but it's just not getting it right. And so it's patients with this can't plan and then perform these small little motor tasks in the correct way. And so it's, combing hair, brushing teeth, shaving, these small little movements that are critical for like everyday life that can be really impacted. And it's incredibly frustrating for these patients. And so there are ways of working around it. This is also something that happens in a lot of other conditions. But again, because that alien limb, that one-sidedness, this is a big problem for patients that have CBD in particular. So just like PSP that we just talked about, CBD also has tau involved. And so we know tau is a problem. Why, how much, what type? This is all still what's trying to be understood. Again, it's thought to be that there are people with certain types of tau genes that are more likely to develop CBD than PSP, than Alzheimer's. But we're still, really early stages of trying to understand this. And so again, just like before, there are other contributing factors here to CBD, but there, again, being a very rare disease, it's very hard to study this one as well. And it's so unlike a lot of the other Parkinsonisms that you'll see here in a second. Any questions on this? This is such an oddball disease. All right, move on. So of all of the atypicals, multiple system atrophy, or MSA, is probably the most common. It's considered also a rare disease, but it's actually fairly common rare disease. This is an MRI of a patient with MSA, and this is what we call a hot cross bun sign. So I'm not sure if anyone's familiar with what a hot cross bun looks like. But this is what they're trying to show you here. It's kind of like, we see this on MRI, it's like, MSA is like one of the first things that's going to come to mind. And this is just showing you what it looks like after autopsy. So MSA is a little bit different in that there's two types of MSA. I'm just going to throw this up here so that you can just at least hear me out a little bit here. But there are patients with MSA who come in and they actually look like they have just run-of-the-mill Parkinson's, and they may even respond to levodopa for a time. And so this can be often, in early stages, is often confused as Parkinson's disease. Then there's a cerebellar type. So this is typically a patient who comes in not with really a Parkinsonism, but more of like cerebellar issues, which is the imbalance, the difficulty walking. And we classify people based on how they, that first time they walk in the office. Are they more Parkinson's, or are they more cerebellar? Just like the last one we talked about, it's younger. This is a younger population. I think this makes it challenging for a lot of people who are suffering with this. This is sort of like, peak years of productivity, and this is when MSA tends to hit. And it is quite fast progressing as well, much faster than Parkinson's disease. Some of the common features behind MSA, and depending on what subtype you have. So by definition, you should have dysautonomia of some type. And I have some of that listed here. So that's like the drops in blood pressure, the difficulty controlling bladder, it's constipation, things like this. For a lot of people, at the end of the day, is if that once MSA progresses along, people start to look the same, and a lot of people will have some degree of Parkinsonism. But again, it's what it looks like and how much faster it changes. Like it's almost month to month where we start to see changes in these patients. And they tend not to respond well or for very long to typical Parkinson's medications. It's a tough disease. We don't know. Unfortunately, we have to say this a lot on this call, but alpha-synuclein's involved in this one as well, just like in Parkinson's disease. But what's different with MSA is that the alpha-synuclein, instead of building up inside dopamine neurons, it's building up inside other cells, and it's building up specifically oligodendroglia, if you wanted to know. But those cells are the cells that actually make the myelin to wrap around the neurons. And they also are the main cells that give like the growth factors and give a lot of health and support to the dopamine neurons. And it's in those cells where the alpha-synuclein is really building up. So that's one way in which it's very different than Parkinson's disease. We don't have a good genetic link right now, especially for the Parkinsonian type of MSA. This is maybe going to change, as we learn more and we can identify patients with MSA a bit better. But it's still maybe some environment, maybe some age. Again, why does someone go on to have MSA instead of Parkinson's or vice versa? This is something that is actually a really hot area of research right now. And I'm looking forward to see where things go with this. This is, again, the hot cross bun sign. So this is what a hot cross bun looks like, in case anyone wanted to know. So this is what that looks like in this part of the brain. There are some other hallmark features that we can see on MRI that, again, there's things that we can look for. If we know we want to see what we want to look at, sometimes just a plain old MRI can give us some pretty good clues as to whether or not this could be something like MSA. And this is just another example of, it's actually a trick question that I would give to med students, like, what's wrong with this brain? And, it's very confusing. You have to know your anatomy very well, but the issue here is really this part of the brain is shrunken. That's it. Everything else is there. The anatomy's in the right spot, like everything's in the right shape. It's just the size of it is small. And that's because that's where all of the atrophy or degeneration is occurring. So this is a real tough disease, but I have a lot of hope that we're going to get some sort of treatment going for MSA here soon. Any questions on this one or prior conditions?
There was one question. In addition to brain imaging, can we use EEGs to look for brain frequency patterns that correlate with certain diseases? Or can it be used to track the effectiveness of treatments?
Yeah, no, EEG is great. Unfortunately, a lot of these conditions occur in parts of the brain that are a lot deeper. So you can see this is like brainstem, and here is like deep inside the brain is where see this arrow here. And typically with the structures that are deep in the brain, we really can't pick up much on EEG. EEG is really on the surface. And so anything that's happening on the surface of the brain, we're really good at picking that up. It's very sensitive. But for any of the electrical activity that's happening deep in the brain, we're just not as good at picking that up on EEG, which is why there's so much imaging that's been driven for some of these other conditions. Now, that being said, EEG it works great for tremor. Like if we can pick up tremor, for example, so some symptoms of these conditions that way. But as far as like we can't really decipher between Alzheimer's and Parkinson's or ALS. We can't really do that very well just by EEG. I wish that'd be easier. The one thing I would say though is what's nice about EEG is that it's all on the outside. It's just on the scalp, and so this is why I think again imaging is a good way of poking or prodding or putting anything inside the brain. We're just taking pictures, and this I think is going to be an important way to understand what you got.
Question: what percentage of people diagnosed with Parkinson's convert to MSA?
Yeah, so it's not that they really convert. I think it's just it's a misdiagnosis, and then we realize over time that okay, this is probably more consistent with MSA, and I would say again, coming in early. So if you take someone who's within, let's say, a year or two from noticing these symptoms, it can take a little bit of time because we need to see how things progress over time. This is MSA is very common. It is often mistaken as PD for many years. Sometimes the only way we can know that this was not Parkinson's is at autopsy. And so I think that it's one reason why it's been hard to study this disease. But I would say on average, it's and I don't know if the numbers are going to be consistent here, but it's like less than 10 to 15%. Maybe we end up changing our diagnosis to something like MSA. But it really depends on what the person looks like when they're coming in. Was there any more?
Yes. That person who said that they have been diagnosed with Parkinsonism by their movement disorder specialist, but they were told that that's good news because they will not progress as much as regular or as fast or as much as regular Parkinson's. Do you have a comment on that?
Yeah, so these are all Parkinsonisms. So there's a discussion on another Parkinsonism coming up that doesn't progress like that. So maybe that's what we're talking about. So let me save that one for a little bit because I think it might be more relevant in a minute. I wanted to bring up dementia with Lewy bodies, DLB or LBD. There's lots of different acronyms that we use here. This is should be somewhat familiar to some folks. So this is actually Robin Williams. I think there was a lot of initial thought that this was Parkinson's. It ended up being Lewy body dementia. I put Ted Turner on here. There's a few other kind of famous folks that have had this because it's the second most common neurodegenerative form of dementia. So it's right behind Alzheimer's. So this is pretty common. Just like in Parkinson's disease, it's this buildup of alpha-synuclein. So this is another synucleinopathy. And just like in Parkinson's, we don't really have a good MRI finding here. This is really a clinical diagnosis, meaning that we have to look at, how the person looks like and how their story has evolved over time, sitting in with them and their family in the clinic. And one thing it's very common is they come in with Parkinson's like symptoms, right? Stiff and slow, problems walking. But the family is usually there and they're usually complaining about the memory issues first. It's not the Parkinsonism, it's the memory stuff that's a concern. And one thing that's kind of a dead giveaway for something like Lewy body dementia is this fluctuating alertness. So what I hear is things like, mom was fine, all morning. And then just all of a sudden, like now she's, behaving very strangely and then back again. And that's another kind of like a hallmark of saying it could be Lewy body dementia. So again, these like episodes of confusion where it's not consistent the whole day through. It's like here and there. One of the other real hallmarks of Lewy body dementia is these hallucinations. And again, this can happen in Parkinson's. It tends to be later stage, older patients. This is something that is a very common feature for something like Lewy body. And it's, I think I mentioned this before on our last talk, but the hallucinations are very stereotyped. So it's like small people, children, animals, things that are kind of low to the ground tend to be the most common type of hallucination. And again, this is it's much more prominent in Lewy body dementia than Parkinson's. It's just similar though, the autonomic dysfunction. So this group of patients tends to have lots of problems with the blood pressure. So again, blood pressure just dropping when you like stand up suddenly or change position quickly. And this can be really scary. It's and it can cause falls and things like this. So again, these are all features that we can see in Parkinson's, but it's just not the same timing and not the same degree. So again, the memory issues are far outweigh the Parkinsonian issues, and that's one big clue to tell me that like this could be Lewy body. I really like this figure. I thought they did a nice job with this, but this is just kind of showing you some of what it looks like over time. So again, some of the early stages, there are some hints even early on that may not be like Parkinson's, but there are some things that are absolutely like PD. So just like the REM behavioral sleep disorders or problems moving, these can always show up in PD, but they will also tend to experience some of the hallucinations and delusions even in the early stages. As things progress, the motor issues get worse, and this is where a lot of the behavior, the thinking issues tend to really pick up. And then even at later stages, that's when the Parkinsonism can be an even bigger problem. And I get asked this a lot. It's like, how can you tell the difference between something like Alzheimer's and Lewy body? This was just a nice little graphic as well to kind of, to me, it was visually just very clear. So, for example, Alzheimer's tends to hit more women than men, whereas Lewy body tends to hit more men, just like Parkinson's disease. And in Alzheimer's, it's the way it looks in the brain. So this is more the plaques and the tangles, whereas in Lewy body, it's the Lewy bodies and the alpha-synuclein that get all clumped together. And so I get asked this a lot, so I wanted to add this figure up. Were there any questions about Lewy body? This is a pretty common disorder. I feel like it's gotten a lot of attention in the news, especially with Robin Williams passing away.
I have a question. On the Lewy body or the MSA, does it respond to exercise?
So, I mean, ultimately, I would say yes, they all will benefit from exercise because this is good for just brain health. For example, exercise is really good at helping release growth factors in the brain, and is helpful in a variety of ways for the immune system. So there are benefits there. It's not been studied like it has been in Parkinson's disease, but there's still no evidence to tell me, don't tell these patients to exercise, right? I still think that there's room for benefit here. I would add my one concern with something like DLB, sometimes the dementia part, the memory issues can really get in the way of trying to exercise. Like this is usually the thing that gets in the way. But the body is meant to move. And so I always encourage just keep moving, because it can't hurt at this point. It really can only help. I think I saw a few more questions come in.
Yeah. Yes. So, are there scans to detect Lewy bodies before autopsy?
That is, I think the Michael J. Fox Foundation was paying like millions of dollars for someone to come up with an alpha-synuclein scan. And so, in fact, what has literally just this year, months ago, there was a company that came out with an alpha-synuclein scan that looked like it might pick up one type of MSA. And that there's still a lot of development that needs to happen, but it's finally getting a little bit close. Alpha-synuclein is really tough because it's everywhere in the brain, and so you have to be able to distinguish the tiny little brain areas that have a lot of synuclein from the synuclein all over the brain. And I think that's been a huge challenge, but it's very clear that the problems with alpha-synuclein look very different in MSA than they do in Parkinson's, they do in Lewy body. And learning about those differences will help us get better at making these scans. But right now, we don't have exactly that. It's a challenge. It's a big challenge.
Also, does Lewy body dementia lead to Parkinson's, or does PD lead to Lewy body dementia? Either of those?
Ooh, that's a good question. I was skirting all around that. So some people believe that Lewy body dementia and Parkinson's are on one spectrum. And there are other camps that feel that these are very separate entities. And so again, this is why I'm saying most patients with Lewy body come in with some degree of Parkinsonism, so a little bit of Parkinson's look. So it's not that they convert over or go back. It's that these symptoms are all the dementia and the Parkinson's come together. But it's always in Lewy body, it's the dementia just overtakes the motor symptoms of Parkinson's, and because is the bigger issue for the family and for the patient. And so it's that sort of that balance that's very different from Parkinson's. But let's just say there's still debate out in the field on that one.
Also, Casey wanted to know, and I would probably save this for the end, can you rank the atypicals from most common to least common?
I did not put that slide in here. This is probably one of the most common. And this goes back to one of the questions that came up before. So this is one type of Parkinsonism that tends to not change very, very much. This is what we call a vascular Parkinsonism. So this tends to be a problem for people with diabetes, high blood pressure, high cholesterol, a lot of things that are kind of endemic to Pittsburgh. And it's, what ends up happening is patients look like they have Parkinson's, but only in their lower half. And so it's a problem just like waist down. And I don't know if you can see it here, but there's all these white spots that you can see here. This is what we call the white matter disease. So these are changes in the white matter of the brain. All of this rim here. This is all part of the vascular Parkinsonism. You can see it on this one too. And this is typically, essentially these are the white parts that you're seeing. These are parts of the brain tissue that have basically had little strokes. So the blood coming up to, these parts of the brain for, again, it's blood pressure problems, cholesterol, diabetes, all these things contribute to those blood vessels not working well or getting clogged up. So you're not able to get the blood flow up to those parts of the brain. And, because of the way the anatomy works in the brain, when you damage, especially these parts here in the brain like this, it causes problems walking because the information going from the legs, from your brain to your legs to move, you're basically interrupting that flow of information with those areas of stroke. And so this really causes big problems walking, and it makes people look like they're walking as if they had Parkinson's disease. It can look awfully a lot like it. And so patients will have, it's mostly, again, predominant walking issues. Again, the same short little shuffling steps, a lot of freezing, like lots of freezing in this condition, and more frequent falls because of all of this. And again, unlike Parkinson's disease, tremor doesn't really show up here because it's really lower body. Now, what can happen is you can have this and Parkinson's disease, and then things get really confusing from there. And so it's an important distinction, because the way you manage this condition versus Parkinson's disease is very different. And sometimes we still try things like levodopa, because if you can find benefit, like let's try it. The one thing that really does help us think that this is something like a vascular Parkinsonism is that it can progress, but it doesn't have to. If you get like the blood pressure under better control, the diabetes under good control, sometimes you can put the brakes on this. But what tends to happen is it's not this like slow progression that's hard to kind of see. It tends to be, you get worse and then you kind of plateau, and then you get worse and then you plateau, and then you get worse and then you plateau, as these different events happen in the brain. So as you add and make these white changes more, that's when the symptoms get worse over time. So that's very unlike Parkinson's, which kind of has a slow but predictable rate of getting worse. So this is actually fairly common and can be fairly static. But there are other causes that can make someone look like they have Parkinson's that don't change over time. So there are things like medications that can make someone look like they have Parkinson's. I have a few of them mentioned here. There are some toxins out there that something is like carbon monoxide. Even there are patients who have pretty serious exposure to carbon monoxide that causes damage to parts of the brain that make them look like they have Parkinson's. And manganese. So welders often have greater exposures to manganese, and this will cause them also to look like they have Parkinson's disease. So there are things out there that, if these are things that you're medicines that you're taking or things you've been exposed to, it can make you look like a Parkinson's, but you wouldn't expect change. You would expect this, if you stop those medicines, for example, it wouldn't continue on. So that's one way to help us distinguish them. There's also one very common one from back in early 1900s. There was the Spanish flu came through, and some patients had an infection in the brain from this, and it led to them basically having very much looked like Parkinson's, behaved very much like Parkinson's. And this was a lot of what was shown in the movie Awakenings. I'm not sure how many people remember this movie anymore, but this was the Robert De Niro character had something like this, and that's what the movie's based on. But a lot of these, again, they tend not to change. So again, lots of Parkinsonisms out there. This is a pretty good list of them. But I think that was all I had. I just want to say happy holidays from the Van Laars, but I think there's lots of questions still.
Yes, so we were just talking about vascular Parkinsonism. Does it respond to carbidopa levodopa at all?
Technically, no. Sometimes if we're not sure, we can try. I think in a condition where, the treatment's really preventative. So again, trying to get the vascular concerns under control. So again, it's good cardiovascular health. It's the blood pressure, it's got to be good. The cholesterol, diabetes, all these things need to be tuned up. That's really the best way to address this. But sometimes we'll still try the carbidopa levodopa to see, because that's, why not? There's got to be some features there to make us think that I want it to work more than, and I think it actually does in these cases. Let's put it that way.
And are any of these reversible?
The secondary ones. So a lot of these conditions where it's a medication induced Parkinsonism, those usually are reversible, which is why you have to know what they are, because you can distinguish them. There are a lot of nausea medications and psychiatric meds, for example, that will cause, looks very much like Parkinson's. But you need to know their medications, because they could be offending, and once you take them off, they should get better over time.
I think you answered this with your last slide, but can vascular Parkinson's be diagnosed with imaging?
Primarily. Was there a question?
Is that while you're alive or post?
Oh yeah, no, this is all while you're alive. This is just a regular old MRI. And this is one of the few reasons I would do an MRI on someone coming in with Parkinsonism. If I couldn't quite tell if there was some component here, if there's dramatically worse, like lower body, again, the legs, the walking, the gait, is way out of proportion for what I see in the arms, that I'm like, we need to do an MRI just to take a look. Because again, managing this is really managing the good heart health. Yeah. What else?
I think that's it. Everything else is happy holidays.
No.
I had one more question, Amber.
Yeah.
With Parkinson's, you can have postural changes in your posture, like your neck. And can that affect blood flow and start creating some vascular Parkinson's from postural changes?
Generally, no. You should, like, your vessels are meant to tolerate being bent. And you have to remember, like, we have multiple pipes going up to the brain. And so it's really hard. Now, that being said, if you have a lot of, cholesterol buildup and it's everywhere, maybe I could think of a situation where it might, but generally your body has been built in a way that you shouldn't be able to lose blood flow to your brain just by positioning of your head.
Is there any way to measure blood flow to the brain?
Yep. There's actually some imaging we can do, but there's also even ultrasound has a pretty good way of you can actually measure the amount of like flow with like Doppler, actually.
I couldn't type as fast as I can talk, so I'll come on.
Yeah, no worries.
I was my neurologist diagnosed me with Parkinsonism based on a clear DAT scan and the fact that I was on risperidone, forget,
Yeah.
for about 3 months, maybe 12 years ago and told me that if, you know, that if that was accurate and was the cause, that I would not get any better, but that I wouldn't really progress because I'm off.
Okay.
Is that
Okay.
accurate?
Yeah, I mean, Risperdal is less likely to do that out of some of those other medications. But it can, in some rare cases, it can be a sort of a fixed problem. You know, we always hope for the best, but usually I would tell patients if they came in and, you know, I saw that there was this history and it's not sort of like behaving like Parkinson's. Again, by definition, Parkinson's should get worse over time. And if that's just not happening, that tells me that it could have been something like, I guess, stroke or medication that was taken. It's rare, but that is not out of the realm of possibility.
And then things like carotid artery blockage and varicose veins issues and high cholesterol and all, that would all be on the vascular Parkinson side, Parkinsonism.
Yeah, so problems in the legs usually tell me that there's probably problems in the neck and inside the head with those blood vessels. So if there are, you know, blockages in the legs, there's probably problems here too. And yes, they can all contribute to a vascular Parkinsonism.
Okay.
Yeah, it's really the tiny little blood vessels that are a problem in here. This isn't the carotids or the big blood vessels. These are the tiny little ones that are really feeding the deep parts of the brain that get injured this way. They're so little that it doesn't take much to block them, and that's why this stuff happens. Which is why, you know, the good cardiovascular health becomes so important, so that you can stop it from getting worse over time.
Okay. Thank you.
Yeah. My pleasure.
Amber, I just have to ask you too, most of these we're looking at imaging and biochemical stuff, and electrical stuff is also important. And then they just came out on the Today Show with vibration technology.
Yes.
Through so I'm wondering, and I just attended a summit on brain regeneration that talks about you could do EEGs at home, like, and they're connected to a thing of it. And if we collect a lot of, and they can develop patterns, especially being used for Alzheimer's, but I'm thinking it could be used for Parkinson's and mapping these frequencies when you're in a bad frequency state. Like,
yeah, it's so Alzheimer's.
Yeah.
Well, Alzheimer's does affect mostly like the cortex, and I think that's one condition where I think we can start to pick up some patterns here. And it's just the superficial parts of the brain just aren't really impacted by Parkinson's as much, and it makes EEG kind of hard to help us. And again, because a lot of where the rhythms are off is again deep parts of the brain. I'm not saying we can't get there, but usually to understand the electrical activity deep in the brain, you have to put electrodes in there to be able to detect it. And so this is like I think we talked about like the responsive types of DBS, for example. That is exactly what they're doing. So it's picking up an abnormal frequency, responding to it. And because you can actually cancel it out essentially if you are able to just be, I don't know if you remember physics, but you can cancel out the abnormal oscillations if you add in the frequency that obliterates it. I actually think that's how the glove works. If they can detect like the frequency of the tremor, you send a signal that's the exact opposite and it cancels it out. And that's one way you could help the tremor just by putting on a glove. Part of what I saw in the video though was this idea that it would help all the other symptoms of Parkinson's disease. I'm a little skeptical, let's put it that way. Now, that being said, is there some sort of retraining that can happen by adjusting, the frequency of what's happening at the hands? Maybe. I'd like to see this in a real formal randomized controlled study. I think this is an essential component for Parkinson's disease, period. But I think there could be some real merit here just to be able to use the hands better and things like this. And we know even from like bicycling that there can be patients who did the bicycling, they actually had some residual benefit even after they were off the bike for a little while. And I think that's part of what they may be seeing with the glove as well. This glove's actually been out for a while, so I was kind of surprised to see it kind of hit the news again, because it's not brand new. But I think it's interesting, and it would be good to put it in a controlled study where you have sham. I don't know how you would do that necessarily with the glove, but it would be really important to understand this technology better.
Part of that too is what you said, like you have this after effect with bicycling.
The bikes, yeah.
You don't have to wear the glove all the time. In fact, they don't,
Mhm.
from that one video, they don't encourage that because you can overstimulate. And from that
Mhm.
statement, I wonder about DBS overstimulating because you're hitting the same area constantly.
I have been wondering the same thing, Donna. And this is actually why you see, these companies trying to get away from this like constant stimulation. Like there's just, you turn it on, it's just going all the time. And so this is where the adaptive DBS is, I think, of great interest. It's meant to be more responsive and more physiologic, meaning that this is really how the brain would normally work, right? It's senses something, it responds. So this is really where the technology is going, because I think you're, as usual, Donna, spot on. And I think that it's been recognized as a potential problem in the long run.
In the same way with PEMF technology and applying magnetic fields for a short amount of time at the right frequency. So you're
I actually thought that's where you're
overall
going with
system for vascular flow and oxygen. I mean,
yeah, I think that you're right. And I actually was meant to bring this up when we were just talking about like the EEG or doing the home stuff, because there's something to that. And even electroshock therapy, it's actually kind of the same thing where it's just a real crude, right, real rough hit where it's just like sudden stimulation. But it's like a big reset, and it will affect not just the surface of the brain, but some of the deep parts of the brain as well. And we know that works, not forever. But understanding that, seeing some of like the magnetic field stimulation that can be done at home, there's something to this. There's something to it. I think we're just still, and it's in its infancy now.
the company that does the EEGs at home is called MindLift, MYNDLIFT.
Yeah. I think I've seen them before. Yeah.
Yeah, but it was very interesting. And they're collecting a big database.
Yeah, and this is really what's needed. And I think taking some of these technologies and all the kind of shared learnings, that maybe we'll have a better understanding of it. This is neuromodulation is really what we're talking about. And we're going to get better and more sophisticated. DBS, I would lump in all of this too. So it's good stuff. This is kind of where we want to see the field going. Really make life more doable for as long as possible.
Yeah, I'm just in favor of neuromodulation without invasive brain surgery.
I get it. I totally get it. Yep. And this is where I think the glove is so appealing,
Or we're getting there, so people should be aware of that before they go to DBS.
Yeah. Especially if it's not expensive, maybe worth trying that. Or exercise
Thank you.
too. Yeah. My pleasure. It's always a pleasure talking to you folks.
Yes, thank you, Dr. Amber and Dr. Victor Van Laar. Happy holidays, everyone. Love your family picture. Let's show it one more
Happy
time,
holidays.
Amber.
All right. This was we were at Disneyland, hence short sleeve shirts, because it was warm.
Well, take good care, everyone. See you.
Yeah, happy holidays.
See you next year.
Holidays in
Bye.
2023.
Yes, bye.
Bye.
Bye, everyone.